Thanks, Jeremy. Yeah, thanks for agreeing to let me do this. Just to remind me if I volunteer for next year. But it is something I think from the millennial era, TLDR, too long didn't read, which I've started using quite a lot, especially when related to journal articles. So we're going to start off just with some disclaimers. So obviously this it's just not possible for this to be exhaustive. Based on some of the other talks that happened towards the end of the year on the Monday meetings, I purposefully didn't explore the HIV and TB um, articles, and I didn't include COVID, mostly because we don't have the vaccines, we don't have the drugs, and most importantly, we don't really have the patients at the moment, except obviously today I had my first COVID patient for a long time. But the journals at the moment are still receiving an absolute deluge of COVID research left over from the last few years. So um, my apologies for consciously excluding those. You would all have definitely read other important papers that aren't in this talk. The papers have really been chosen based on some clinical relevance or some potential impact or some potential benefit that I think we all might get. For a lot of the details of the journal articles, I've tried to keep it broad brushstrokes. So yes, I agree the devil is often in the detail. But if there are any major queries regarding super duper detailed statistics issues and what's happening in the different subsets of the patients in the trials, I promise you I've got all the PDFs. I'll be very happy to share them. And if there's a topic that you would particularly like for next year, if this is something that you want me to consider for next year, you can send in a request, sort of like an old radio show, and you'll have to wait a year for it. So this is a picture taken from Helen Joseph during registrar time, and it really just makes the perfect background image for any PowerPoint presentation. And we're going to start with an article that should have been discussed at a number of different journal articles, just one to ease us into the afternoon, which was a paper from the NEJM on antibiotic treatment for 7 versus 14 days in patients with bloodstream infections. So we know sepsis has a high morbidity and mortality, and we often have talks on sepsis and talks on new antibiotics, describing how early and appropriate antibiotics improve survival. But there's not a lot of information on knowing exactly when to stop, and this has often been poorly studied. And I find with this query, when we have our stewardship rounds, there's often this balance of anxieties between giving a too short a course with potential clinical failure or relapsing infection or resistance versus too long, which would lead to adverse events, C. diff, resistance among non-target organisms, and the cost. And other literature before this has dealt with shorter is better type articles on pneumonias and intra-abdominal infections, pyelonephritis, cellulitis, but most have excluded bacteremias. So this trial was a multi-center, open-label, randomized, controlled, non-inferiority trial. It was along the sort of New Zealand, Australia area. So there were 7 countries, 74 hospitals. And one of the limitations in the commentary on this paper was that there was no US representation. So it was all New Zealand, Australia, Canada, and a number of others. And patients that were included were those with positive blood cultures with the pathogenic bacteria. And there were a number of instances where the exclusions were related to situations where we know that the duration is going to be longer. So like staphylococcal bacteremias, prosthetic valve endocarditis, vascular grafts. And so they really just tried to focus on conditions or situations where there were obviously no conditions requiring a longer duration. The primary outcome was death from any cause at 90 days. So 90 days after the positive blood culture results, and there really were an unbelievable amount of secondary outcomes. And I'm sure we'll be seeing data from this, papers from this data set over the course of the next few years. And just some of the secondary outcomes were death in hospital, death in ICU, admission to ICU after the diagnosis, relapse, C. diff, length of stay. And certainly one of the first questions that I asked when starting to read this paper was obviously which were the common organisms, and we see it's mostly Enterobacteriales, the E. coli, Klebsiella. A few percent are gram-positive, Enterococcus and CNSs, and Pseudomonas, which certainly in our hospital, in our setting, often is treated for longer durations, only unfortunately made up a few percent of the cases. These were the sources of the bacteremia, so a lot of urinary tract infections, intra-abdominal infections, and the majority were community-acquired infections. Some were from the hospital ward, and only a few percent were from ICU-acquired infections. And you'll be surprised to know that the primary outcome, death from any cause within 90 days, was non-inferior. So the 7-day group versus the 14-day group was non-inferior. And there were a whole host of secondary outcomes that were also documented, particularly related to the number of days in hospital, the number of days in ICU, ICU management, so vasopressor support and ventilation, and in the majority of instances, there was no major flag for a shorter duration. So this paper, I must say, has certainly changed some of the practice within in our ICUs at my hospital. The 14-day sort of biblical number has sort of become the stuff of legends, especially in the sicker patients. But I think for those who are less severely ill, patients with bacteremias who are being managed in the wards, certainly our move has been towards changing our practice towards a 7-day duration in those patients. Another interesting paper I found along the lines of stewardship and antibiotic usage was based on upper and lower respiratory tract infections, which was something I hadn't heard of before, something called an umbrella review, which summarizes systematic reviews versus a systematic review that looks at the primary studies. And I just had visions of these poor guys filled with their offices filled with papers strewn all over the place, with hundreds and hundreds of primary studies, and on top of that, a whole host of the systematic reviews that have summarized the primary study. So this is an umbrella review looking at the systematic reviews. Antibiotics for respiratory tract infections make a big portion of the total antimicrobial usage, and that's something that I think we see across the board. No matter where you work, what environment you work in, what level of care you are exposed to, from primary care in rural areas to quaternary care in a city center. Respiratory tract infections are a large driver of antibiotic use. And there are a whole host of trials on this. And yet there is still a practice of prolonging the course of antibiotics. And so The paper raised an interesting question. So is this really a knowledge gap, or is it an implementation gap? And I think often we see papers, maybe a primary study looking at something like this, and you think, well, what does this paper actually add to the knowledge base that we already have on this particular topic? And often it's not so much that it adds something that we didn't know or that we didn't suspect from the get-go, but really just the highlighting that there are certain practices that are deeply entrenched despite all the evidence against it. And so these clinical entities were the ones that were reviewed in this paper. So community-acquired pneumonia, acute exacerbations from COPD, hospital-acquired pneumonia, sinusitis, and tonsillitis. And I've really just included this because it was something that I'll be honest, I've never seen in a paper before. So we know often when we're looking at a research paper, the sort of final line will always be more research needs to be done on this particular topic, or an evidence gap still exists. Further questions need to be answered with further studies. But this paper was quite clear where they stood on that. So apart from patients in the ICU and those who are immune compromised, no more trials, systematic reviews, or meta-analyses are needed to examine the efficacy of 5 days of treatment. There's insufficient evidence to support an antibiotic treatment shorter than 5 days, and high-quality trials are necessary to evaluate its efficacy. We know that in clinical practice, pneumonia is often treated for longer than 5 to 7 days, indicating an implementation gap of available evidence. In a number of the other clinical parameters that they looked at, the acute exacerbations of COPD, which I think is probably one of the biggest culprits of unnecessary antibiotic use, again, no need for more RCTs or meta-analyses on the efficacy of 5 days of treatment. The hospital-acquired pneumonia trials, usually of very poor quality evidence. So the one thing about this paper was that it really drilled deep into the quality of the primary data, the biases, the stats, the patient profile, the outcomes, looking at the quality of the data. And unfortunately, often for things like hospital-acquired pneumonia or ventilator-acquired pneumonias, the data is quite poor. The one thing I found interesting for strep pharyngitis, tonsillitis, or pharyngotonsillitis, so we know often only a small number of patients require antibiotics. The meta-analyses generally are pretty poor quality. And the results showed that 5 days of cephalosporins achieve clinical and microbiological cure, but cephalosporins are considered unnecessarily broad for this indication. But if we use penicillin, 10 days is needed. One of, I think, all of the infectious diseases doctors' sort of primary bugbears is trying to get our colleagues to de-escalate antibiotics. This looked at hospitals in the US in patients with suspected sepsis. Very often we hear, particularly when referring to things like the Surviving Sepsis campaign, that we've got to give early antibiotics, hang time less than an hour, we've got to give these organisms a big clap and cover broadly, and then we can de-escalate after 48 to 72 hours. But there's actually very little data on de-escalation practices. And so this was a retrospective study, a huge number of patients across a whole host of hospitals, over 200 hospitals in the US, with community-acquired sepsis. Initially started on anti-MRSA and anti-pseudomonal treatment for a couple of days, and then they followed it up to see if once the cultures, once they came back and there weren't any resistant organisms, what was the de-escalation practice. The majority of anti-MRSA cover was vancomycin, and the anti-pseudomonal drugs were piptaz, cefepime, and mero. And in the de-escalated patients, there were over 36,000 of them that were matched with non-de-escalated patients. De-escalation was only noted in less than a third of cases, and this was mostly in large sort of teaching hospitals in areas. And we see that's in terms of acute kidney injury, C. diff infection, and mortality for those patients who had their antibiotics de-escalated or the cover narrowed. I've just included this quote from Brad Spielberg that I might have included in a prior talk, but it's worth going through again. Over time, two predominant schools of thought evolved to define antimicrobial durations of therapy. The first was based on the historical fact that in 321 CE, Constantine the Great decreed that there would be 7 days in a week. That is the actual historic basis for therapeutic durations as multiples of 7 days. We have described these durations as Constantine units to underscore the absurdity of using the decree of an ancient Roman emperor as an evidentiary basis for modern therapy. The second line of evidence was based on the number of metacarpal bones that evolved in the hominid hand, which has resulted in 5 to 10 day durations. This left a better place with diminished antimicrobial resistance if we had instead evolved as three-toed sloths. Right, then just to change things up, onto fungal infections. A few papers on fungal infections. So this was from the Journal of Infection, a paper on persistent candidemia caused by different Candida species. We know that recognizing persistent candidemia is critical. We've obviously often have to look for occult foci, so thrombophlebitis, endocarditis, deep-seated infections, the mortality from candidemia itself, and obviously from persistent candidemia, is extremely high. And the article mentions guidelines. This is from a European cohort, recommending daily blood cultures until 3 consecutive days with negative cultures. So this was a retrospective observational multi-center trial, 3 hospitals in Italy and Spain over 5 years. Looking at patients with Candida bloodstream infections, and the primary outcome was persistent candidemia. The majority of Candida species in this cohort was Candida albicans, so that was over 40%, and parapsilosis 38%. My apologies to the mycologists online. My nomenclature is a bit all over the place, and I've tried to keep it a little simple. If we look at the right-hand graph, this breaks down the different species that are the main culprits for persistent candidemias. So Candida auris and parapsilosis were the majority. So we see 40% and 30%. So 40% of Candida auris will become persistent candidemias. About 30% of parapsilosis infections will become persistent. And of note in this paper, which I found quite interesting, regarding their auris samples, was that similar to our situation, fluconazole was 100% resistant, but they have had over 50% amphotericin B resistance in their Candida auris isolates. I must say one number I wasn't expecting was how high the persistent candidemia rate is, so 25%, and this is in over 1,000 samples. They also found no association between the initial antifungal and the risk of persistent candidemia. Moving on to another paper that mostly because it's something that we are starting to see a little bit more, and the evidence base for managing these patients is quite poor, and often it leads to email chains and WhatsApp groups and some sort of quasi-review of case reports on how to manage these patients. And that's prosthetic joint infections from Candida species. About 1 or 2% of arthroplasty procedures become infected, and of those, about 1% are fungal. Often they're underreported, and almost all of them are from Candida. And it's something that we are likely to see more of, what with aging populations, the number of joint replacements going up, and also the number of immune suppressed hosts. So this was an international multi-center retrospective trial looking at 19 hospitals, seven countries, and they included patients who had Candida from 2 or more intraoperative specimens or sterile samples. Candida, in my experience, being on the receiving end of WhatsApp consults, for not just these patients, but for anything relating to Candida. And often we have to try and interpret how significant the results is. And so this article was looking particularly at Candida in 2 or more samples from the operation time of operation, or from sterile samples. And they looked at cure defined as the absence of signs and symptoms by 2 years. So the majority of prostheses were hips and knees. That's unsurprising. I think that's our experience as well. And I've highlighted just in the middle block just how many surgeries a lot of these patients had. So they had an average of 3 procedures. And we see that over 70% of these patients have had previous infections before. And as you can see, not necessarily from Candida, often from bacterial causes. And the bacterial causes are the usual suspects, the staphylococci, coagulase negative staph. And I've included some of the clinical parameters, the biochemical parameters. Sometimes diagnosing something like this can prove quite challenging, because very often the prosthetic joint infection doesn't sort of follow our standard pattern of a severe inflammatory response. As you can see, there only a few % of patients had fevers. Majority of patients had some, or half of patients had some inflammatory signs. A lot had fistulas draining or wounds breaking down. And we see that the biochemical parameters are also not terribly helpful. So the take-home message from this trial was that in prosthetic joint infections from Candida, in this cohort from Europe, more than half were from albicans, about a third were parapsilosis. Co-infection was in half of the cases, mostly staph or coagulase negative staph. And in terms of the surgical strategy, this is always a very tricky and delicate discussion to have with the surgeon, because the implant retention, so the debridement, antibiotics, implant retention made up a third of the surgical strategies, 1-stage exchange a third, and a 2-stage exchange a third of the cases. And unfortunately, clinical failure was associated, besides for age greater than 70, was with the sort of a more conservative surgical approach, which, as infectious diseases doctors and microbiologists, not getting source control seemed to be sort of a doomed strategy from the get-go. A lot of these patients were treated with monotherapy, and I must say the times that we've had patients like this before, the question about combination therapy always comes up. And unfortunately, this paper doesn't really answer that question, and hopefully something that will have some answers sometime soon. Another paper that I included, just about PCP and pneumonia non-HIV patients, something that we certainly seeing more and more we have the luxury of ECMO in our facility, and we do a few times a year have patients that are for a variety of reasons presenting with pneumocystis pneumonia in the HIV negative status. And this paper looked at about a decade's worth of data, and just looking at the trends of underlying conditions and the therapeutic regimens that a lot of patients were receiving that may be immune compromising them. The majority of the medications were ones that we know are high risk medications. So about a third were in patients who had suspected at-risk medications, so DMARDs and a lot of mTORs and purine synthesis inhibitors. And these are going to be medications that we'll be seeing more and more. And I know for certainly the practices that I work with, the appreciation of bacterium prophylaxis, besides for high-dose steroids, for a number of the other conditions, giving trimethoprim, sulfamethoxazole prophylaxis is not really a consideration. And I think we barely getting the sort of long-term steroid patients onto prophylaxis. So this was something that I thought might be worthwhile to consider as we see more and more of these patients. Then the next section was really just because of an interest that I have in the condition, and I was trying to think about what a reasonable analogy would be for it, and I thought of it more as the line in the ID Big Five. So a week ago, Lucille mentioned the little five, and I often think about the sort of the heart attack, the MI of infectious diseases, the one that sort of gets you out of bed. And for me, that's endocarditis. In terms of it being the line in the Big Five, it's something which is not that rare, so we do see it. You kind of got to look a little bit hard. It's not as hidden as let's say a leopard that almost no one sees, except for I'm sure some of you that will no doubt tell me. It's life-threatening. It's always quite a thrill to deal with it, and I must say, endocarditis is something that I think as doctors fascination. Its incidence is increasing, and one thing that I thought about with this paper really was including it just to really show that with all our excitement about medical advances and the things that we can do, endocarditis is one of the more humbling conditions to deal with, and really highlights the limitations of humankind and what we can do for certain medical conditions, and we'll look at that in a moment. So this was conducted within Swiss hospitals. So the epidemiology was centered more so away from rheumatic heart disease and more towards things like degenerative valve disease, dialysis, cancers, IV drug use, and obviously there are a number of cardiac and vascular devices that are being used in older populations. And the paper notes a shift in developed countries away from strep towards Staph aureus. So it was a nationwide retrospective study. over 10 years, looking at data from a central federal statistical office. It looked at all patients hospitalized with endocarditis, and it looked at a number of the usual mortality, ICU stay type outcomes. And just for the naysayers who are dismissive of using data from a Swiss Federal Statistical Office, I just wanted to remind you that Albert Einstein worked on his groundbreaking thesis while he was working as a Swiss patent office clerk. So just to bear that in mind. The trends over a decade are really quite humbling, I must say. The hospitalizations, we'll talk about the mortality, I think, in the next slide. But the hospitalizations we see over the decade have increased. The cases per 100,000 hospitalizations pretty much stayed the same, maybe a touch higher. And here we see the etiological agents, the Staph aureus climbing to be the most common bacteria, the strep species declining over the decade. And it was quite reassuring to see that other situations like major developed countries still have culture negative or unknown pathogens. And in this cohort, it was around 30% of the cases had no organism. And this just shows so in the top left-hand corner, the mortality, so that's in-hospital mortality, then the 6-month mortality, and all really just a bunch of straight lines, which is really quite disheartening. And that's with all of the latest advances on diagnostics and antiseptics and newer agents, surgical techniques, the TAVI procedure, which is being increasingly used in patients that wouldn't necessarily have been a candidate for a valve replacement, are now getting the sort of minimally invasive aortic valve repairs or replacements. And the only thing really to note that might be slightly optimistic is the length of stay. The graph in the bottom right-hand corner, and this may or may not tie into a recent shift towards oral regimens for infective endocarditis. But otherwise, unfortunately, quite a sober set of graphs. Right, another sort of big paper, one that was in the Lancet Infectious Diseases, was something that's sort of been in the ecosystem for some time, the doxycycline as post-exposure prophylaxis. STI rates are increasing, especially in MSM and transgender women. And this, there had been prior trials on this, but this included the final results of the open label extension of once the efficacy of doxy had been shown. And the graph on the right just shows the reduction in gonorrhea, chlamydia, mostly after just one dose of doxycycline. I think the next, so this slide just shows the original paper from 2023, same authors and same cohort, just showing the initial protocol, which was giving a dose of doxy 24 to 72 hours after unprotected sex at clinics in San Francisco and Seattle. And the Drug Safety Monitoring Board actually stopped the enrollments and discontinued the standard care group because the marker of effectiveness was reached. So what about some of always a question with anything related to prophylaxis is what sort of resistance or what sort of complication pattern might we see from broad use of an antibiotic in this situation. And the initial paper and this paper, which is from a similar group of authors, the main author is from the original paper, just showing the increased rates of resistance to Neisseria gonorrhea. And the question was raised from the initial Lancet paper was whether there would be a decrease in effectiveness of doxycycline over the course of the next few years. Right, on to a few things parasite related. So these maps were taken from an epidemiological study looking at the trends of, or the incidence trends for sub-Saharan African countries, or for a range of districts from 2005 to 2015, that's on the left, and on your right, 2015 to 2020. And we see that earlier on, 2005 to 2015, in the majority of areas, the incidence was declining of Plasmodium falciparum. And more recently, unfortunately, and for a variety of reasons, whether they be climate change, funding issues, political unrest, the rates of falciparum incidents have been increasing in a number of regions on the continent. So Charlotte had touched on this, I think it was last week, looking at the South African data, but this was a paper in JRD looking at artemisinin resistance markers in southern Zambia. So artemisinin resistance was first noted in Cambodia in 2006. And in East Africa and the Horn of Africa, it's been detected since 2014. This paper looked at two main mutations, so the P441L and A578S, two mutations that were detected with deep sequencing. And the P441L is associated with delayed parasite clearance. And I think a lot of us get to see patients that are coming to South Africa after having traveled to Zambia or that area with malaria. And this, unfortunately, is something that we are likely to be seeing more of. It's not a test that is routinely offered. It's not offered in the commercial laboratories. I don't think it's offered within the NHLS, but just from chatting to Charlotte earlier on, it is available on request. And I know that with some of the patients that we've had where there are concerns about poor response to treatment, or patients with recurrently recrudescent malaria, we have had the opportunity of having those samples sent to the NRCD and having these mutations looked for. And of note, just in the image on the right, we see that the prevalence of the P441L from 2018 till now, so just in the space of, well, this was up to 2023, just in the space of 5 years, we see the prevalence breaching what the WHO has marked as a 5% resistance threshold. So this, for those of us who manage malaria, particularly in patients who have traveled through sub-Saharan Africa, unfortunately something that we need to keep an eye on. And then just maybe some more optimistic news. I wanted to just put one of the vaccine trials, and there are a lot of prevention trials on malaria in some form, whether it's new vaccines, new vaccine targets, new prevention strategies in endemic areas, long-term preventative prophylactic regimens in people living in endemic areas. So quite an exciting amount of work going into this field. But I wanted to just talk briefly about just one vaccine that looks promising and might be one to to keep an eye on. So the two vaccines that are currently in circulation, the RTSS and the R21, work on the sort of pre-erythrocytic vaccines. They target the liver invasive sporozoa. So we see that on the diagram. But these vaccines don't induce a blood stage immunity against the parasites. And so this trial from Lancet Infectious Diseases in kids in Burkina Faso was looking at, it was a phase 2B trial looking at a RH5.1 vaccine with the adjuvant molecule, the matrix M, which had been used in prior vaccines. And it looked at, it was a double-blind randomized trial looking at the response after 14 days from the last dose, looking at the incidence of malaria. The control vaccine was a rabies vaccine that the children received. And there were different dosing strategies for the vaccine. Looks like the jury is still out on what the best dosing regimen is for this one, but it was overall about a 55% vaccine efficacy with no serious adverse events. So just to end off, I'd asked Jennifer Kutsia, microbiologist at Ampath, who's usually very up to speed with the articles, and she sent this amazing exchange through to me. So it sort of speaks to diagnostic stewardship, which is something that's becoming quite a actively practiced thing in my hospital, and I'm hoping that Tom Boyles is online so he can help talk us through this. But it was an initial commentary called Revisiting Diagnostics, Erythrocyte Sedimentation Rate and C-reactive protein. It's time to stop the zombie tests. And the commentary was really talking about how often the CRP and the ESR are ordered unnecessarily. I know in a lot of ICUs, there's a reflex order, a standing order to have daily markers requested. In the end, the final sort of portion of the paper talks about how these tests have got poor test accuracy. There's no unified cutoffs. There's redundancy with clinical info. So often, even though we know someone is frankly septic, we still can't help ourselves and order a CRP when they're spiking fevers and coughing up, bloody sputum. We just can't help requesting tests when we do know that a patient is septic. And most importantly, there's a failure to show clinical impact. A follow-up letter in response said, yes, we agree with most of what you've written, but we do feel that the CRP is useful for ruling out infections and sparing antibiotics. And it's also useful for prognosticating. And there's an exchange looking at the different randomized trials on this topic. And then, not to be outdone, Spellberg et al. End off a reply to the reply with, we fully acknowledge that giving up the ESR and CRP tests is an uncomfortable proposition and that we are at differing stages of grief. In popular culture, zombieism is generally incurable. The 2013 romantic comedy movie Warm Bodies gives hope that immunity to the zombie virus is possible and practice can change. I highly recommend for those who work in hospitals who have daily CRPs done for ICU patients and unfortunately even often in the wards, these sort of three exchanges are really enlightening. And so just to end off, For those of you who are involved actively in research, I know that sometimes it can be very disheartening. It's quite a laborious and thankless slog. And in terms of the more esoteric papers that I found, was one that made it into the Journal of Infectious Diseases, looking at an Epstein-Barr virus genome from a museum penis sheath from Peru. And so just if you're having any doubts about your chosen career, just remember someone out there has published on this topic, and happy to tell you any questions. So thank you.